Hello everyone and welcome to another APSAD Insight webinar. My name's Jim Hunt and I'm one of the nurse educators based here in Roma Street in Brisbane as part of Insights. Today we're going to have a presentation on a subject which I think is probably going to be pertinent for many people that use substances, and it's the subject of loneliness. And I think it's probably an interesting time to present this subject with what's happening around Australia and the rest of the world regarding COVID. So I think it's going to be an interesting one to see what the outcomes of the study are. Before I pass over to our speaker today, I'd like to start by acknowledging the traditional owners and custodians of the land on which we're meeting today, and pay my respects to any elders past, present and emerging. I'd like to extend that welcome and respect to any Aboriginal or Torres Strait Islanders that might be joining us in webinar land. So welcome and thank you for joining us. So today we've got an Associate Professor, Genevieve Dingle, who I believe is based in one of the universities in Brisbane, and she's a psychologist who's got several years of experience working as a clinician in AOD. So I think it's going to be somebody that will have a voice that will be relevant to many of the clinicians that are tuned in. So without much further ado, please welcome Associate Professor Genevieve Dingle, who will be presenting on loneliness. So thank you very much.
Many thanks, Jim. I'd also like to extend and acknowledge the traditional owners of the land that we're meeting in Meanjin, and also, of course, to the custodians of the lands that you might be on as you tune into the webinar today. So good morning, everybody, and thanks, of course, to the team at Insight and APSAD for having me. I'll just get this going. Okay. So the topic of loneliness, it is an interesting one. So I know that loneliness is not a diagnosis, and so it has tended to fly under the radar a little bit with my own profession of clinical psychology, but also other health professions. We don't have a lot of training in how to assess and how to treat, if you like, loneliness. And it seems to be only in the last few years where we've seen a number of spotlight reports. So just to give you a few that you may have seen, the Australian Loneliness Report back in 2018. We've seen that the UK government has actually got a whole loneliness strategy that they've been rolling out. In the US, they did a big survey of 20,000 Americans through a company called Cigna, and they've generated this report on the US Loneliness Index. We've got non-government think tanks like What Works Wellbeing putting out scoping reviews and advice on how to measure and tackle loneliness. More recently, we saw the first annual report, so a whole year of the loneliness strategy in the UK. And even in journals like Journal of American Medical Association, there was a paper not long ago about this behavioural epidemic of loneliness. So I feel like loneliness is on the radar and is being sort of given a fair bit of attention in the last few years across at least the Western world. So that brings me to what are we really talking about when we talk about loneliness? Well, you'll see a number of different definitions. The one that seems to have the most, I guess, the most established use in the literature is this one, Peplau and Perlman. So loneliness is commonly described as a painful emotional state resulting from a discrepancy between your desired relationships and your actual ones. So it is different, although it's been bandied about and used interchangeably with social isolation, they are actually different concepts. Social isolation is an objective state of having few social contacts. So of course, social isolation and loneliness can co-occur, but theoretically it's possible to be lonely even when you're surrounded by a lot of people. And conversely, it's possible to be socially isolated and to feel quite happy about that and to not feel lonely. So trying to keep that subjective and objective definitions a little bit separate in our minds. There's also quite a lot of discussion about different types of loneliness. So the most common three would be emotional, social, and existential. So where emotional loneliness has been defined as resulting from a lack of that close, intimate attachment with another person. So that could be a parent, a partner, a best friend. So that really close, intimate knowledge of another person. Social loneliness, on the other hand, is coming from a lack of a sort of friendship or broader social network, a part of a group of friends with shared interests and activities, that sort of thing. And existential loneliness doesn't come up as often in the literature, but it's that sense of ultimate aloneness, the fact that nobody else really understands what it's like to be you. And existential loneliness does seem to come up more in the context of health literature, things like palliative care, cancer treatment, those sorts of things that are incredibly isolating just by virtue of the experience itself. So just so that people can, if you're interested, you can go away with some tools from today that you could use in your own work. I thought I'd give you a little overview of some of the measures that are commonly used of loneliness. So one of the most commonly used is the UCLA loneliness scale. There are different versions of this. This is the 20 item, and you can see the items there. The little ones with the B's on them are reverse scored on a 1 to 4 scale, and then you just add them all together. So you get a total score in the range from 20 to 80, and any score of 43 or above is thought to be sort of significantly lonely. So someone that you would actually have to sort of work with on their loneliness to address that. If you're wanting to tap into the emotional and social loneliness, the De Jong-Gierfeld is the most commonly used. So there's a number of different versions of this of different links, and they're on that link at the bottom of the slide there. This is the shortest one, the 6 item, and as you can see, there are items about the emotional expression of loneliness, as well as the ones more to do with having people around you that you can connect with and trust. This is probably the shortest one that's been validated, the Hughes. So it's just a very easy tick box 3 item score. I've used this one with older adult studies, particularly ones who are frail in hospital and that sort of thing. And if you're using this scale, it's also recommended to include an extra measure of direct loneliness. So these ones are really talking about the feeling of being isolated from others, but they recommend that you add an item that just says, how often do you feel lonely? So a direct loneliness item. And this one is one that some colleagues of mine at the University of Queensland have been working on, which is much more dynamic. So this is where you get your clients to sort of draw up a social identity map of the groups that they consider they belong to. And there's a number of different things you can see in that example on the screen in terms of the importance of the groups, how much support you get from the groups. You can depict the relationships among different groups that you're a member of. And in this case, we've overlaid some dot points with sort of red, yellow and green dots, meaning the red dots are for where there's very heavy drinking norms for the group or substance use norms for the group. And then the green is for people who are non-users or in recovery. And then yellow is sort of more casual users. So that a person can have a snapshot of their social world as well as the risks and supports in terms of their recovery, if they're in treatment, for instance. Okay, so we do know that loneliness is widespread. So this is from the APS loneliness report. So this is using that 20 item UCLA loneliness scale, and you can see the cutoff score there at 43. And basically the means for all of those different adult age groups, what was above that cutoff for loneliness, except for actually the oldest adult group in the 65 and over, which is a bit unusual because most other reports around the world have shown that the 2 most prone groups are the young adults and the older adults, but this one didn't quite map onto that. And this infographic from the What Works Wellbeing conceptual report is a nice one because it shows that, of course, all of us go through life transitions where we are left sort of more disconnected from our social groups. So there's a number of them shown here. So things like just even leaving the home and the family to go off and start school, finishing school and either going into the workforce or going into university. Experiences where you might be isolated from people within school, so bullying, for example. And then over on the right-hand side, things like becoming a parent for the first time, separation, divorce, losing your job or going into retirement, changing where you live. So all of these are things that most of us will come across at some point. And so I guess what that says is that loneliness occurs quite naturally, and we all will feel that from time to time. But there are some subgroups within the community that are much more at risk. So as this report here, this is from Health UK, basically, if you've never been married or you've been separated, divorced, you're more at risk of often feeling lonely. Also, if you're a single parent, you're in the kind of the highest risk group, according to this particular report. And things like being unemployed. So there are some people who are much more prone to feeling lonely often. The reason that it is important for us in the health services is that it's a really big player in terms of correlations with physical and mental health issues. So this big review by Holt-Lundstadt and colleagues showed that actually the effect of loneliness on our life expectancy, our mortality, is equivalent to smoking 15 cigarettes a day. And it's actually worse for us than things like obesity and having a sedentary lifestyle, so a lack of exercise. And those are really well-established big ticket items when you think about health risks. So it just tells you how important those social factors like loneliness are. We also know from Michelle Lim's work here in Australia that it's associated with a 15% increased risk of depression, and then work elsewhere is showing increased risk of stroke, and a whopping 64 increased risk of dementia if you're lonely. So, you know, it really is something that we've probably undervalued as a risk factor and that we do need to be more aware of and identifying in our client groups. So I'd like to now talk about loneliness in the context of substance use in particular, and I'd like to foreground the work of my colleagues, Isabella Ingram, who's just finishing her PhD and has led a lot of these studies at the University of Wollongong, and her primary supervisor, Associate Professor Pete Kelly, who many of you will know. So in this one, this is a systematic scoping review. And so basically 41 studies met our criteria for inclusion in this review. And I won't go into too much detail on the actual review process, but the kind of take-home key findings were that loneliness is related to poor physical and mental health. It is related to substance use, the quality of people's relationships, and stigma and the perception of being mistreated by others. And these were all within, of course, substance use populations. In terms of theories that have been used in these sorts of studies, cognitive theories have been proposed. So there are a number of patterns, and I'll talk more to this later in the slides, in terms of the onset and the maintenance of loneliness. But there hasn't been a lot done in terms of how we should go about as clinicians measuring and targeting those cognitions in our treatments. In fact, only one loneliness measure, the UCLA loneliness scale that I showed you earlier, has been validated within substance use populations. And only a single loneliness intervention specific to substance users has been trialled, and actually it didn't work. So basically the scoping review, which is in this month's drug and alcohol review, is highlighting that there's an awful lot of work that we need to do in this area. Now, this study is that Bella also ran was from earlier in her PhD, where she got some empirical data. So going in to residential alcohol and other drug treatment services in New South Wales, and she just did survey measures of loneliness in 316 adults. So just highlighting that the great majority were either single or had been separated, divorced or widows, which we've just said is, you know, a risk factor for loneliness in itself. And she found that 69% rated that loneliness was a serious problem for them, and nearly 80% felt lonely at least once a month. So it was an ongoing, frequent experience for these folk. And then comparing that back to the figure of 25% or 1 in 4 that was reported in the Australian Psych Society Loneliness in Australia report. So we're looking at much higher figures within the substance use population. This is another paper that's come out in the most recent issue of Drug and Alcohol Review. And this is a really, if there's one paper you take away and have a read of, it would be this one. So this one speaks in much more detail about the actual experience and perceptions of loneliness. So it was in-depth interviews with 20 people aged a range, so 20 to 63 years, who were in residential treatment in New South Wales. And so we did a thematic review, thematic analysis of the transcripts, and found that actually substance use and loneliness drive each other. It's not clearly that one comes before the other. And the following cognitions really stood out from what people were describing in these interviews. So things like mistrust, lack of perceived support from others, low self-worth, fear of negative evaluation. So I'll give you some quotes that give you an example of each of these themes. So for mistrust, Henry is saying, yeah, it takes a while before I can fully trust someone because, I don't even trust my family. And so I built, like a wall. I think as you hear these quotes, you'll probably reflect on a number of clients that you work with yourselves or you've worked with in the past, because these are really common sorts of things that people do say. Over here for perceived lack of support, Jason is saying, I was lonely and I was surrounded by heaps of people. But if I had one person there that cared about me and knew, I wouldn't have felt lonely. If no one cares about me, I might as well just write myself off. It's like I use it as an excuse to just get fucked up. Low self-worth, Jessica is saying, there's a very deep sadness of unworthiness, I guess. And there's also a responsibility in it too, because a lot of the loneliness comes from self-destruction in the way of relationship. And then Nathan at the bottom here is saying, I really can't share in the meeting because I'm just scared that I'm going to be judged. So that's that fear of negative evaluation or scrutiny from others, and sort of that inability to actually reach out and share your experience with others. This body of work on loneliness is actually sort of building on top of some earlier work that myself and other research groups internationally have been looking at in terms of social connections and belonging as factors in the onset and the recovery from substance use. So I'll just flash up a couple of those. In this is another interview study with people who are in Logan House therapeutic community. And we asked them about the onset of their substance use, and then how they managed to, come into the therapeutic community, and then what they were thinking about after leaving. And we actually found that there were 2 social connection or social identity related pathways. So you can see there at the top of the screen, these are people who described that they had quite positive social group and social identities, like being a student or being a partner or family person or being a part of a job occupation, which was lost when they started to get into that really addictive cycle. Whereas at the bottom there was a lesser known pathway where people were actually quite disconnected and isolated to start with. And they actually saw the onset of their substance use as being a valued gain of a social identity. Now I'm part of this group of people that use substances together and maybe do crime together or do other things together. But that's actually, to me, fulfilling a need for a sense of belonging. So this was a really interesting sort of second pathway that we found in these descriptions. Of course, to a point, and then the substance use became problematic in a number of ways, and then people were sort of prompted to enter the therapeutic community. And pretty quickly, they all developed what I've called a recovery identity. So a sense of belonging within the therapeutic community to this new set of people who are in recovery together. And then there were 2 pathways coming out of that. the one at the top where people were trying to re-establish those positive identities, sort of get back with their kids or their families, go back to uni and study and that sort of thing. Or in the bottom case, it was establishing new identities they hadn't had previously. So thinking about who they really were without the substance use. So we do know that it's not just a question of having people around you if you're lonely. It's about choosing wisely about which people you can be around that are going to support where you're going with your recovery and the life that you'd like to lead. And this earlier work has just been, I guess, replicated in a larger project that colleagues at Turning Point in Melbourne and myself up at UQ and also some people at Deakin Uni have been involved in, called the SONAR, or Social Networks and Recovery Project. So this one has 307 adults going into 5 different therapeutic communities around Australia. We asked them to do those social identity maps and also to rate their sense of themselves as part of a substance using social network, so their user identity, and also their sense of themselves as being part of a recovery network or their recovery identity. And we did that sort of soon after they'd come into the TC and then again at 6 months. Of course, some people had left the TC by 6 months and quite a few were still going. So we looked at these interim outcome measures, so commitment to sobriety, psychological distress symptoms on the K10, and also personal wellbeing at 6 months. That's the reference down the bottom of your screen there. And what we found is that this is on a 1 to 7 scale. Identification as a substance user went down over the 6 months. So people are moving away from their substance using groups and seeing themselves less in terms of being a user. And there was no difference between the 3 broader substance use categories. So you can see in blue, that's the alcohol being the primary substance of concern. The ATS is the amphetamine type stimulants, and then the other category. So all of them had the same trends there. Meanwhile, all of them stayed quite high in terms of identity as part of the recovery community, which is probably not that surprising given that most of them were still in the TC across that 6 months' time. The important thing, though, is that the extent to which there was a discrepancy between seeing themselves as in recovery more than seeing themselves as a substance user, which we call identity differentiation, was a really important predictor of how they were doing with those 6-month outcomes. So if you can think about sort of variance in those 3 outcomes, commitment to sobriety at 6 months, personal wellbeing, and the K10 symptoms, what you've got here is sort of the 100% variance, if you like, in those scores at 6 months. And, you know, after you've already accounted for their demographics and their treatment history, their identity that they scored as they came into the TC is the dark blue there. And then this big sort of dark green chunk, sort of about 20 to 25% variance in each of those outcomes, is accounted for simply by the discrepancy between the recovery and the user identity. So again, this is just echoing that who you're surrounding yourself with and who the groups and communities you're identifying strongly with are actually very important influence on your own substance use and your attitudes towards that and your ongoing recovery. Okay, so let's have a look now at what we can do about loneliness in substance using populations. So this meta-analysis came out, I guess, nearly 10 years ago now, and it's actually looked at 50 different studies in which they had some sort of loneliness intervention, and they sort of sorted them into these 4 broad types or categories. There's interventions that are targeting social skills, so actually teaching people social skills. There are ones that are aimed to enhance people's social support. There are ones that increase opportunities for social contact, and there are ones that assess and intervene with social cognition, unhelpful thinking patterns. And actually, when they looked at this in the meta-analysis, they found that interventions targeting social skill development, sorry, my cat is running havoc here beside me, and increased social contact and support only have a really small effect on loneliness. So actually, they're not particularly useful. There were some with that targeted maladaptive social cognition that showed some promise. But overall, myself and my colleagues are thinking that just targeting an individual's loneliness and they go away and try and work on it by themselves is probably not the best way to address this problem. We're thinking that actually what we need to do is address a social issue in the social context and the community context. So I'm going to show you a few examples that we've come up with and started to trial in our group. So this one is a program called Groups for Belonging. So this is myself and Kath Haslam from the University of Queensland, working in collaboration with Bella and Pete from the University of Wollongong. It's a new 6-session group program, and it takes some components from the earlier Groups for Health, which Kath has led, and I've got the main reference down at the bottom of your slide there. So Groups for Health is also a group program that is aimed to map people's social networks and to help them to reconnect with existing groups and also develop new groups that are supportive of their health. So this one is adapted some of those components specific to the substance use treatment recovery folk, but we've really integrated quite a lot of other components that are more broadly CBT and mindfulness to help clients to overcome cognitive barriers to connecting to others. So we know that it's not that easy to just say, okay, there's some groups around you in your neighbourhood and your local community that you're interested in. Most people will find it difficult to just go along to a group that they don't know anybody in, particularly if they've got all those cognitive barriers that we talked about earlier, like mistrust and fear of negative evaluation and self-stigma and a whole lot of that stuff going on. So this one targets all of those. So just to tell you a little bit session by session of what's in this program, in the first session, obviously we try and create a safe space and welcome people in. We do a lot of educational work to highlight some of the stuff I've just told you about how important our relationships are to our health and mental health. We do the social mapping activity, so people have that really interactive snapshot of what their social network looks like and where the risks are in terms of substance use. Then they go away with that map and they build on that in all the subsequent sessions. Session 2, we talk a lot about loneliness. We normalise that feeling. We talk about the links between loneliness and unhelpful thoughts, and then we do a mindfulness activity, which really helps people to sort of sit with and understand and tolerate loneliness rather than it becoming a driving force for unhelpful substance use. In session 3, we talk about the difference between quality and quantity of relationships. We try and draw out people's relationship values using this activity, A Party in My Honour. We look back at our social maps and we try and say, well, which of these groups that I am a member of actually reflect my important values. And we look at the thing about social identities coming from our important group memberships. In session 4, we talk about those 2 identity-related pathways. We get people to reflect on their own sort of pathway. We talk about relationships meeting our social needs. We start to do some work with our maps on reconnecting with earlier social groups. And we do some specific activities about how to overcome knockbacks if people are contacting someone from a former life. How do they deal with potential rejection or knockbacks, people who are not really interested in reconnecting, and overcoming feelings of stigma to reach out to others. In session 5, we start looking at developing new group connections. So looking at people's interests and values, looking at their leisure time. We specifically target those fear of negative evaluation thoughts, and we develop a set of SMART goals for social change. So a lot of these clients are really familiar with developing SMART goals, but usually it's for behavioural change, so actual substance use target goals, whereas in this program it's all about the social change that will support then the substance use change. And in the last session, we do a lot of troubleshooting about the things they've tried to do in terms of their social goals. We target the mistrust cognition. We do some use of everyday music listening for overcoming negative emotions. And we do some targeted work around fear of showing feelings to others, which we know from earlier research is quite a marked component of social cognition in people in substance use treatment. So in last year, we did a feasibility pilot on the new program, Groups for Health. So we recruited 41 people in 3 residential services in New South Wales. We also did recruit from We Help Ourselves in Queensland, but that was an aftercare program, and the data is a little bit different, so it's not included in this particular paper here. So in this sample, there were 63% males, average age of 42 years, and a range of different primary substances of concern. As you can see there, the majority were amphetamine users. So as I said, 41 people signed up to do the Groups for Belonging trial. And only 20 completed the program. One of the reasons for this is that at one site, a new anxiety and depression program was scheduled on top of Groups for Belonging, and was seen as quite a core program. So unfortunately, we lost quite a number of people there, and 8 people actually left the service during the trial. So we did have large attrition there. But the average number of sessions attended was 3.7 out of the 6, and there were no differences at baseline between the people who supplied us post data and those who didn't complete the program. So just to show you some of the outcomes, first of all, on the Rules 8, which is an 8-item shorter version of the UCLA loneliness scale, we've got a really nice significant drop there from pre to post. On the de Jong-Gierfeld emotional loneliness, that's also significantly improved or decreased. In terms of wellbeing, that's increased significantly. We've also got a nice drop in user identity, which, as I said earlier, is quite a big indicator of ongoing successful outcomes. We had no significant change in commitment to sobriety, and it remained high at both time points, which is a really good thing. And there was a small decrease in cravings, but it failed to reach significance. And then in terms of with the feasibility trial, we're really interested in whether clients feel comfortable with the materials, and we got a lot of verbal feedback from them, particularly Owen O'Neill, who was my master's student on the project, got a lot of interview-based feedback on components of the program. But in terms of their ratings, you can see here, these are percentage ratings of different things like I enjoyed it, I was able to have a say, I'd recommend it to a friend, etc. So those are all looking fairly positive. And I'm just going to spend the last few minutes talking about a second intervention. So this is one that is broader than just substance use. This is being used quite widely for people who are isolated and lonely, particularly in the UK. So the UK is really leading on social prescribing at this point. But I'm part of a project here in Brisbane that is looking at social prescribing within the Australian context, and we're aware of a number of different networks that are being trialled around Australia. So social prescribing, if you've not come across it before, is a non-clinical pathway where people who are seen as being quite isolated can get a referral. So it has 3 components or pieces. The first is a referral to a link worker. So that could be made by a GP or health worker in primary care, but in our network that I'll talk about in a minute, we're actually taking self-referrals and referrals from community services. So it could very well come from a drug and alcohol service, for example. The person has a meeting or a series of meetings with the link worker who's got really in-depth knowledge of all of the group-based programs and services in a geographical area, and they have a good knowledge of the facilitators of those groups, and they will get to know the person and understand their interests and their needs and whether they need special access and mobility support or any of those sorts of things. And they work together to come up with a group program or service that they would like to engage with. They can then help them engage and follow them through. So there's a lot of follow-up to see if the person has fit that group or community, and if not, then they can go back to the drawing board and try something else that's available. The link worker has been called different things in different places. So you might hear community development worker, wellbeing coordinator, social prescribing coordinator. And as I said, that person has to have really solid on the ground and up-to-date information about what's available in the area. And even though a lot of health workers, social workers, and even GPs will have been referring their clients to these sorts of things in the community, often they don't have time to chase up and update these lists of what's available and when and who to contact. And so they can't really help and support and do the follow-up that is required by a lot of our folk. So just very quickly, I'm part of the Ways to Wellness Social Prescribing Network, which is in Mount Gravatt on the south side of Brisbane here. In our operational model, it's a little bit different to the UK model in that we're not only taking referrals from GPs, we're taking them from the wider community and also from the lonely person themselves who can just read our website and refer themselves in. They come in and talk to our link worker, or she will go and visit them at home. They basically look at their interests and needs, and if they have a clear understanding of what they'd like to do, they can be referred directly to groups. So over here on the right-hand side, some examples. It might be the men's shed, it might be a book club, community choir, something like that. And if they don't have a clear understanding of where they'd like to go, they can actually do the Groups for Health program. So that's the original program led by Kath Haslam, where we actually get them to self-manage, do their social identity maps, look at sort of what kinds of groups reflect their values, and work on developing a new group connection in the community. So bear with me, I'm just going to show you a little tiny bit of video footage that's from a recent video series that's been put out by Health and Wellness Queensland, which actually features the importance of social connectedness to wellbeing and shows you a little snippet of this Ways to Wellness and our link worker, Elise Ma.
An individual and community level are vital for our physical and mental well-being. In fact, they can help prevent illness and may even add years to our lives. Social inclusion, support, engagement, participation and networks can help foster opportunity, a sense of purpose, belonging, dignity and even fulfilment in all of us. Social worker Elise Ma also enjoys helping others reap the benefits of social connection. She's taking part in an Australian first initiative called the Ways to Wellness Social Isolation Project. Elise's role involves connecting people to social groups, catering to every conceivable interest.
How do these activities actually help with social isolation?
Physical activities are going to improve physical and mental health and well-being, and I can certainly assist with linking people into those exercise and fitness groups, walking groups, sporting clubs. But it's the sense of belonging and inclusion that comes with being part of a group that I think really has the most benefit to people who are experiencing social isolation and loneliness.
The Ways to Wellness Social Isolation Project began in 2019 at Mount Gravatt in Brisbane. It's open to anyone, but you need to be referred by your GP.
I think what sets us apart from other services is that I can provide that literal hand-holding for people. So not many people enjoy walking into a group of people that they don't know or participating in activities that they've never tried before. So I can come along with them, I can introduce them to the facilitators and I can participate with them. So it just ensures that they have a positive experience and they're not doing it on their own.
Harshpreet Singh Kohli is also
Okay, so that was just a little snippet from that 10-minute video, and you can see that on YouTube if you'd like. There's 6 different episodes, and they're all on different ways that people can self-manage their health and well-being. So I guess I should say that Ways to Wellness did get started last year and was going great guns, and then the research that I'm leading had just started. Literally, we got about 4 people to do their first time point survey when COVID hit and all of the groups had to close down. So we've been on hold for quite a while and haven't got much to say about the data at this point. So we're really keen to sort of see those groups reopen, which should start happening next month, and continuing what is a 3-year evaluation of ways to wellness. So just to finish up today, a couple of take-home messages: that we know loneliness is common among people who use substances and is a driving force for substance use. Helping people to connect with others who support their recovery is related to sustained healthy outcomes. We also know it doesn't have to be an alcohol and other drug specific group or community. Obviously those are really important, particularly early on in treatment. And of course there are a range of those mutual support groups, you know, AA, NA, GA, Smart Recovery, a whole range of them that we know of, but also non-alcohol drug specific broader group activities such as offered by social prescribing can also address loneliness, so we can take away one of the drivers of substance use. We also know that people have cognitive barriers to connecting with others, and these might need to be addressed in treatment. So those things like mistrust, fear of negative evaluation, stigma, and I'm sure there are others. So we are actively looking at these at the moment. And just a little plug that Groups for Belonging shows promise as a tailored intervention for people with substance use disorders who want to develop their recovery social networks. And so, of course, I just want to say a big thank you to all of my students and colleagues that I've worked on a number of these different studies with. Of course, it's not something that you do by yourself. I'm a great believer in the value of groups and communities, and I think it comes through in the sorts of great work that we're doing together. So I'm happy to take your questions, and thanks for listening.
Thank you very much, Genevieve. Really interesting and well thought out presentation, so I appreciate that. I've got a few questions, so if you can be patient with us, we'll work our way through them. Firstly, we know obviously from your presentation, loneliness is definitely an issue. Are there any trends showing whether loneliness is increasing or decreasing over previous decades?
Yeah, so it's a bit of I've been watching what's happening with the huge range of different studies that are going on during the COVID social distancing, for instance. Some reports are showing that social isolation has obviously gotten a lot worse because people are physically isolated from each other, just not seeing as many people. But there's mixed reports about whether loneliness is getting worse or not. So some are saying it is worse and some are saying it hasn't changed. So I think we're still in the thick of the pandemic. We're not really sure how it's all going to play out. But I do think there are people at those transition points that are going to be much more badly affected. So I know in my own household, for instance, one of my daughters had just started at a new school, at high school, and the other one had just started at uni and literally made no friends before the shutdown. And so those are just, normal kids going through their life who are quite isolated and, yeah, because they haven't got anyone that they can just have those daily chats to, apart from perhaps their old friends. So those sorts of things, I think, will affect some more transitional groups in the population. Yeah, in terms of the broader question, though, has it increased over time, like in the last decades? There is some indication that is the case. We're again not entirely sure why, but some researchers are speculating it's because of the much higher use of online communication as a sort of primary way of connecting to others, which is very helpful and very convenient, but has a lot of downsides actually as well, that people are not seeing each other face to face as much, and that can help. Some people are much more prone to loneliness because of that.
I think that kind of leads into the second question that I had, which is obviously it seems strange in a way that we're talking about loneliness when, when I was a child, if I wanted to connect with someone, there was pretty much only one way to connect with someone, and that was to physically go and see that person, maybe write a letter. Now we have a plethora of different ways that we're able to connect, but it seems that we're that it seems to be a different form of connection. And that's what the question is. Do you think there's a difference in the value of connecting with someone face to face, for example, as opposed to connecting over a social forum or a Zoom group such as what we're doing now, for example?
Yeah. So look, I feel like there's a lot good to be said. So I'm not sort of here to slam sort of social media and that sort of thing. I think that does help people feel belonging, a sense of belonging. They can be connected to a number of different networks on social media. So it does have a place to play. I think what we need to do is look very carefully about the difference between quality and quantity. So we do know that having a few really high quality attachments is most important in terms of health and well-being, that you can have 100 people that you kind of have this superficial relationship with, potentially online, or just people you know around you in class or at work. But actually, if you're in trouble, you wouldn't be calling on them. Do you know what I mean? So they're just not that quality of relationship. And I think that's the difference that we're seeing coming through.
The difference between a Facebook friend and a personal real friend. Yeah.
That's right. That's right.
And you mentioned that there's also not a huge amount of study in this area, or not a huge amount of reports, research in this area. What would you like to see being done?
Well, look, I know there's been a huge amount of work done on like social network analysis, social connections, groups and communities. So there's a lot of foundation to build on here, but they haven't actually been measuring loneliness directly. So there is a difference between your networks and whether you feel lonely or not. So I feel like we need to put those two pieces of the puzzle together more. And yeah, work at that sort of interplay between the individual factors and the social and community factors. I think we really need to think outside of the one-to-one therapy kind of model to get the best answers with people and to support them to generate their own social connections.
Sure. Your presentation also highlighted the fact that loneliness is such an issue that it actually has a decreased life expectancy. Is there any research around whether loneliness equates to physical health complications during life? And with the reduced life expectancy, is there any particular risk that those people are more prone to regarding the reason why they pass away, as it were?
Yes, so it's a fascinating area. I did have on one of my slides down the bottom a link to Mihalopoulos and colleagues' paper, which does a review of a lot of these links and mechanisms that link loneliness with health and health behaviours. To give you an example, they've found that people who are living in a relationship, so have some kind of partner or spouse, are much more likely to, practice healthy behaviours like exercise and healthy eating, and they're also more likely to take medication as directed. And there's a lot of those sort of more relational things where you've got a point to someone who might be reminding you of those things or making it more valuable. Right down to studies on things like immune system markers, so biomarkers of how your immune system is functioning or how your stress hormones are functioning. So there's a number of ones that are looking at the mechanisms that might link a social factor like loneliness with actual health and disease and outcomes like life expectancy. I feel like there's still a lot of work to be done in that area, but it's definitely happening now, which is good to help us understand.
What do you think the prognosis is for social prescribing in Australia? Do you think it's something that will grow and expand?
Look, I really hope so. I was asked to speak about this Ways to Wellness project as part of a roundtable in Melbourne in November, and it was organised by the Royal College of GPs and Consumers Health Forum Australia, and there was also representation from the Allied Health Council of Australia. So it was high level kind of people from health services around the room, big gathering of people saying, yes, this is important. How should we do it? How should it be funded? How should all the, risks and referrals and all of that sort of stuff be done? So it's definitely starting to get some traction on the agenda. There are different funding models. So our particular network here in Brisbane is funded partly by sort of state government, Department of Communities, and partly by federal government through the PHN and primary care. So it's been cobbled together in Australia. We really need to think about it in much more serious and sort of sustainable ways if we want to do it properly. But what we're doing at the moment is just building the evidence, so getting the research of how it works and who it works best for and all that sort of thing. And then I guess we take it to policymakers and funders and try and sort of get it to the next stage.
Sure. I should let you know there was a lot of positive feedback about the group for belonging process.
Okay.
And many people have asked, is this something that's manualised that can be, that other services can adopt and deliver?
Yeah, look, and I hate to speak for my colleagues, but I think we're all really keen to partner up and try and get some good funding for a big trial. So we're very happy to hear from people in alcohol and drug services who would like to partner with us to do that. We've only just done the pilot at this point. We're about to do some training with We Help Ourselves, who've been part of our pilot, and so they'd like to train up their staff to do a longer trial. But I think we're open to sort of sharing the love, because we'd like to see how it works with different other kinds of services as well. So please do get in touch if you're interested and you've got a service that might be open to adding. And so it is an interesting one that it has fit quite well within a residential sort of full-time treatment service, as well as in We Help Ourselves. We did it as part of their aftercare, so once a week outpatient kind of mode. It seemed to be really well accepted in both. So I guess we're open to suggestion.
Cool. And people can contact Insight and we can forward emails if they don't have it, and we can hook those connections up, which would be good. Somebody's asked in relation to the pilot that happened, is there any plans for a longer term follow-up to see whether the changes are sustained, I guess?
Of those particular people, not at the moment. I guess that was a little bit time limited because Bella wrote it up for her PhD and submitted it. So it's kind of, the resources has pretty much come to an end. But yeah, we are keen to get some funding and to get a more long-term, larger scale trial going. I'm
sorry to interrupt, but the second part of that question you may be able to answer is, what do you think, if there was a long-term follow-up, what do you think the prediction would be? Do you think it would be sustained, the changes?
Well, so I think we're seeing early changes that if people have embedded themselves into quality relationships and group connections before they finish treatment, it will help them to naturally sustain those afterwards. So it's kind of beyond the end of the treatment phase into the more maintenance phase, if you like, in their home communities. And so I feel like that's one of the beauties of this, is that you don't have to keep paying necessarily for treatment if you've got a really quality network around you that will help you work on your goals for recovery. So that's kind of, I do feel like we'll get some positive longer term outcomes, but I guess I'm just, it's conjecture at this point.
Yeah. Some people want to tax your brain about strategies, so particularly rural and remote, connecting in rural and remote areas. Do you have any advice for people out there? And building on from that, also in particular with COVID at the moment and social distancing and self-isolation.
Yeah. Look, I hear you. It's been very frustrating and very difficult during COVID, of course, because a lot of the lovely things that are available across rural and remote areas, they're often really well set up for community connectedness. I mean, that's kind of what they do. There's a community centre or an arts hall or an active men's shed, or there's those sorts of things across rural and remote areas of Australia. We're actually quite good at doing those things. I think the difference is that we're trying to position that within the health remit rather than it just being seen as this sort of recreational extra thing that some people do. I think if we put that within health and recovery in this case, it sort of changes how people think about engaging in, whether it's, park run, or whether it's a sewing group, or whether it's, playing cards once a week. It really is about just finding something that you love that's available in your local area that is not involving drugs and alcohol, and you're away. So I do encourage people to work with their clients to explore what they're interested in and do a bit of their own social prescribing, and do that early in treatment rather than leaving it as a sort of bit of an afterthought. So that would be my kind of cut down version of groups for belonging message.
Thank you. I can only say that I wholeheartedly support that. When I started in AOD as a clinician many years ago, my focus was always on trying to build people's lives rather than worrying about the substance as such, which 30 years ago used to get me into trouble for not knowing what substances they might be using that particular week, but I could tell you what groups they were getting engaged in and all that sort of thing. And for me, that's always been my focus. So it's nice to see that this is actually coming out now. I've actually got a colleague, Dan, who stood next to me, who's itching to ask you a question. So I'm just going to stand to one side and let Dan ask a question.
Okay, excellent.
Hi, Genevieve. Thanks for the presentation. Yeah, really enjoyed it. It was interesting to hear the impact on health is greater than obesity and sedentary lifestyle. So obviously it's an area to look further into. I was hoping with the bit of time we've got left just to ask you to talk a bit more about the cognitive barriers, because I was thinking that some of them could be very real, that, you know, negative evaluation and lack of support and
yes, absolutely. Yeah, so not to at all suggest that these are not real barriers. They're really important barriers. And of course, this starts to make sense of why we get such high comorbidities, for instance, between substance use and PTSD, or substance use and social anxiety disorder or depression. Those are the common kind of cognitive themes that you'll see coming up with those kinds of experiences. So there are really important reasons why those are there. And so what we do is we just sort of highlight, measure and give feedback on what people's cognitive barriers might be, and then try and work with them to find a middle ground, something that's comfortable for them to work with. So in the case of fear of negative evaluation, if you were seeing that in a social phobia kind of treatment, you would start to get people to take more chances and to put themselves out of their comfort zone and do a bit of exposure work and sort of see if they can change their cognition on the basis of experience. It's a bit like that. You know, you do have to take some chances before you realise that some people are safe to be with. So it's that kind of process that we're encouraging people to do. It's not about sort of removing them completely and saying you're wrong. It's about how can we manage within this to connect with others, because we know that will be good for your health and longer term outcomes.
Thank you.
Thanks, Dan. The final question I've got, which you've kind of hinted a little bit on one paper, somebody's actually asked, are there any particular books or journal articles that you would recommend to kind of supplement this presentation that you've done today for people that want to do further reading?
Yeah, so, well, I guess that some of the hot off the press is the 3 studies that Bella Ingram led that are all in this month's drug and alcohol review. So if you've got access to that would be a great place to start, because of course she's referencing a lot of the earlier work. So the scoping review will give you kind of a nice handle on all the loneliness work that's been done in drug and alcohol populations. If anyone's interested in talking about some of the broader sort of social network stuff, they can always email me and I can send them some articles, because there's quite a lot of work across the world really in social network analysis, social connection, social identity and recovery. So yeah, it depends what they're interested in reading, I guess.
Sure. And by all means, get in touch with us at Insight and I will forward that on to Genevieve if you want particular information. I'm sure she would be only too willing to help you with that.
I probably should also just add there just very quickly that families are a group. So I don't want to miss out the fact that people's families are a really important part of their recovery. And so there is also a body of work around couple therapy and family-based therapy for substance use as well, of course. So that would go in the mix